Listening to Ask Your Herb Doctor on KMUD Garberville 91.1 FM and on the web at www.kmud.org. We're also live streaming this program to our Western Botanical Medicine YouTube channel, so you can listen live right now on our channel by searching Western Botanical Medicine in the search bar on YouTube and clicking on the live stream. So tonight's radio show is a continuation of last December's show on small intestinal bacterial overgrowth. Going to give a quick resume of last month's and then carry on to finishing up the subject as best we can with the herbs that are indicated. It's a big subject for sure, so difficult to grab it all together and bring it all into one place in the show that we have. But I also wanted to spend a little bit of time during this show on some breaking news about cardiac arrests and mRNA vaccination that's come to light. So my name's Andrew Murray. My name's Sarah Johannesson Murray. Welcome. We're both licensed medical herbalists who consult with clients with a wide range of conditions. Our website is westernbotanicalmedicine.com, and you can visit our site to see a list of our organic medicinal herb tinctures, and our contact details are there also. Alternatively, we can be reached on our toll-free number 1-888-WBM. And our Western Botanical Medicine Twitter's accounts handle is at WBMHerb, and our YouTube channel is Western Botanical Medicine. So links to both our Twitter and YouTube channel are also on our website. Well, welcome to those who've tuned into the show, and for those who listen off-air or through the archives, good to have you as subscribers and listeners, and Happy New Year to you all. 2024. It's going to be a good year, right? Okay, I hope it is. Okay, so more evidence coming out about what was always said about the mRNA vaccines and cardiac arrests, especially for athletes and other high-performing individuals, and we'll share exactly why that is. Research came out from a cardiologist in England on the Tuesday, I think, of this week, so very recently, and the same doctor, who's a cardiologist, is going to present a webinar about it, so I'll give you that information a little bit later on. But to carry on from December and the gastrointestinal kind of discourse we were having with the subject of SIBO, I just wanted to kind of wrap up last month very quickly and then just continue to where we left off. So as I mentioned last month, in terms of the gut and its microbiome and its function, we wanted to go through the kind of different etiologies of the different individual pathologies frequently associated with disturbance of the gut and its microbiome. And so SIBO, for those of you who have not heard that, it's an acronym for small intestinal bacterial overgrowth. And then you have IMO, and that's intestinal methanogen overgrowth. We'll go through the difference between the hydrogen-forming bacteria or producing bacteria and the methane species, the archaea, that are not even microbes. Then there's SIFO, and that's small intestinal fungal overgrowth. And then You also have the overlapping gastric pathologies of IBS and IBD. So IBS being irritable bowel syndrome, one of the most commonly diagnosed GI diseases, and IBD, inflammatory bowel disease. And this group of pathologies mainly is Crohn's and ulcerative colitis. So these are truly inflammatory marker mediated, so neutrophil mediated and other white cell derived agents that are there to neutralize microbes and other reasons for triggering the immune system. So it's really the body's own autoimmune attack, as it were, on tissues, and that is probably one of the more damaging effects of GI disturbance, both those two diseases, Crohn's and ulcerative colitis. The others certainly have their own discomfort, and certainly something that most people with these conditions, whether SIBO, EMO or SIFO, certainly want to do something about it, because eating food and all the GI disturbance that's accompanied with metabolizing food with the presence of these quote-unquote bad bacteria are certainly something that drives people to consult with doctors and herbalists and other people that deal with these conditions in alternative ways. Okay, so to carry on, the other thing I should mention, of course, is that from 7:30 till 8 p.m. We open up the lines and invite people to call in with questions either about the current subject, or if they have any questions about any other alternative medicine related subjects that they should call. 923-3911, that's area code 707-923-3911. So from 7:30 till 8 o'clock, we'll be taking the lines and taking calls. Okay, so in SIBO, small intestinal bacterial overgrowth, looking at it from a microscopic point of view, preparing a slide of the endothelia, you'll see that these endoscopic and histopathological appearance of the mucosa is usually healthy, unlike the inflammatory bowel diseases, where you'll see a lot of inflammatory activity and derangement of cell activity due to these kind of chemotactic agents that are unleashed by our own body in an attempt to cure something which is not typically there as a bacterial or viral or other microscopic pathogenic form. It's more as an autoimmune sort of attack. So this mucosa then in people with SIBO is normally healthy. You don't see any real difference to regular non-suffering patients.
That's so strange, because you would think that if you have bacteria in your small intestine, which is the first part your food hits after it leaves your stomach, so normally that whole area of your small intestine is sterile. It doesn't have any bacteria in it. So you would think that if it had these bacteria, these methanogens, or the sulfur,
The hydrogen
sulfide, bacteria, that they would be causing irritation, since they're not supposed to be there. But funnily enough, the intestines look normal when you look at them.
So there are non-specific endoscopic changes that may include things like mucosal edema, so you'll see swelling. Loss of vascularity is a commonly seen visual appearance. Patchy erythema, so kind of reddening, patchy, blotchy type appearance to the endothelia, or rarely ulceration. So unlike the inflammatory bowel disease, which is totally characterized by erythema and ulceration and bleeding as a principal finding, SIBO doesn't really have any of these on a kind of histopathological basis, and nothing will be seen in the lab when these things are plated up on slides. So the non-specific histopathological findings may include things like villus blunting. These are the little projections that you'll find in the intestines. The intestine itself is not very smooth in terms of it being a tube that the food is passing along, with the nutrients being removed from it and brought into the general circulation into the hepatic portal vein. The inside of the lumen of the intestine has millions and millions of tiny, tiny little projections that point into the lumen, or the hole through which the food is passing. These like finger-like projections. You'll see, rather than being distinctly finger-like, they're kind of blunted, so they may not end in a kind of, not point, but they may not end as projections. They may just be squared off, and this is due to some part of the disturbance of the whole process.
So is that in the small intestinal bacterial overgrowth?
Yeah.
Or not?
Yeah.
It's not in the Crohn's and the ulcerative colitis?
No, in Crohn's you can have this completely because of the inflammation, but in SIBO they'll find some of this. I'm just saying that there are some overlapping characteristics, but unlike ulceration and bleeding and inflammatory disease.
Isn't it with the little hair-like projections in the large intestine when you have ulcerative colitis or Crohn's or celiac? Don't those hair-like projections just get completely
they get completely
destroyed?
Removed. Yeah.
Right.
It's mainly the small intestine that has this. The colon's really just all about water reabsorption. So unlike the small intestine, that's all aimed at pulling in all the nutrients from the food that you eat and bringing it into circulation. The large intestine is really just about consolidating that waste, and all the mass of the bacteria that's there forms the bulk of the stool. And that's something that I think most people don't realize, is that when you look at the feces, that the greater bulk of it is microbiological content rather than the food. So the colon's main use is to remove the liquid waste, the water, reabsorb the water so that we don't dehydrate, which is exactly the problem in diarrhea. So when you have diarrheal conditions, especially with chronic diarrhea, and especially in third world countries, this can be the death of children when they have uncontrolled diarrhea because they dehydrate. Obviously they lose all the electrolytes and salts as well, but so these other non-specific histopathological findings may include things like villus blunting, cryptitis, intraepithelial lymphocytosis, which is where there are white cells present as a kind of immune response, and eosinophilia, again another type of white cell that is visible on microbiological evaluation.
So the white blood cells are coming in because they sense there's bacteria there that aren't supposed to be there.
Yeah, and it's basically a non-specific response, immune response, but it doesn't result in the same ulceration and damage that occurs when there's Crohn's or ulcerative colitis, because it's not inflammatory as such. It doesn't cause the body to unload all these cytokines and other agents that are based on destroying things and lysing cells. So fat malabsorption from bacterial deconjugation of bile can lead to weight loss, diarrhea in some cases, as it can literally alternate with diarrhea and constipation, and fat-soluble vitamins, so A, D, and E, K deficiency. Now, these deficiencies can sometimes present initially outside of the diagnosis of SIBO or similar malabsorption syndromes. Now, carbohydrate malabsorption causes abdominal distension, and this is from hydrogen, carbon dioxide, or methane production. Excessive flatus and acidic stool can also be present, and decreased mucosal uptake, as we mentioned, the kind of villus blunting that occurs, can cause protein malabsorption, obviously because the villi are there to absorb all these nutrients. And then SIBO generally is associated with normal or elevated folate levels, but decreased B12 levels. So kind of B12 is one of those kind of markers really that you'll see on people's blood work, and typically these levels are below what would be considered as a normal reference for B12.
So back to that carbohydrate. So does that mean that people with SIBO would be more likely to suffer from bloating after they eat starchy fermentable carbohydrates, because it directly comes out of the stomach and it feeds those small intestinal bacteria?
Right. Yeah. Like I said, some people suffer with the diarrheal form of it, and so certainly in the diarrheal form, because of the decreased transit time and it passing through you very quickly, you can get malabsorption as a very well-known factor, and people can find it very difficult to gain weight. And there are other people that have exactly the opposite. It's quite an interesting characteristic. Some of the constipation form of SIBO can cause people to gain weight because they're actually pulling more out of their food than would normally happen because it's sitting around so much longer.
Right. So if you're more constipated, then you're going to be more prone to gaining weight.
Yeah.
But what about the fat-soluble vitamin deficiencies? Those are occurring because these bacteria are altering your food and you're not able to absorb it because these bacteria are taking it up.
Right.
So that's quite interesting. Why some people, because there are people who need I've noticed with clients over the years,
Right.
there's people that need a lot more vitamin D than others, or a lot more vitamin A than others.
Yep.
And this is probably linked to the different bacteria. I mean, we all know we're a different mix of bacteria in our intestines, but now that they're discovering these specific bacteria in the small intestine that should not be there, and people are usually getting diagnosed with it when they have symptoms of abdominal distress, like bloating or diarrhea, like you're saying, or lifelong constipation. There's a lot of trouble we experience from the wrong bacterial balance. And I think that's why Dr. Pete's diet helps so many people when they avoid those fermentable carbohydrates, because then you're not feeding any bacteria in your small intestine immediately upon exiting the stomach.
Okay, so the other thing I mentioned about the vitamin B12 deficiency, which can be present in people with diagnosed SIBO, this is because of the ileal mucosal damage to cobalamin binding sites. So we mentioned this kind of villus blunting as one of those kind of microscopic findings when they plate up small biopsies of the tissue. So the fact that this blunting occurs, it also causes a concomitant cobalamin binding site deficiency. Also, so vitamin B1 and B2 deficiencies occur due to bacterial overutilization. So there are definitely some nutritional deficiencies that occur because of SIBO. And then also, you mentioned, Sarah, vitamin D. That's definitely a very changeable vitamin in people, that most people, in terms of what's recommended as an RDA for vitamin D, they might mention something like 2,000 IU. I know it's gone up from probably 800 20 years ago, but now it's 2,000. But really, it tends to be much more like 5 to 10,000 IU for some people. And you can get people tested that have, 20, 22 nanograms per deciliter vitamin D levels, and they may be taking 5 or 10,000 IU, whereas some other people might get values of 30 and 40 and 50 nanograms, and they may be only using 5,000.
Well, that's why it's such a good idea for people who want to supplement with vitamin D to have a blood test done, 8 to 12 weeks after you start on your 2,000 or 5,000 international units per day, because then you can see what you're at. You don't want too much of this vitamin, and you don't want too little. And the magic number seems to be 50.
Mm-hmm. So severe vitamin D deficiency, which you don't often see from malabsorption specifically, and this could be with people that have really decreased transit time, who just really hardly process their food, or they have inflammatory bowel disease where they're really not able to absorb this. Can present with the condition known as perioral numbness, hand and feet paresthesias, muscle cramps from the hypocalcemia that can follow vitamin D deficiency. Now, SIBO has been implicated in developing non-alcoholic fatty liver disease as well, and hepatic encephalopathy. I think these are more the serious forms of it, for sure. Now, diagnosing SIBO. The typical standard test is a non-invasive breath test detecting, utilizing carbohydrates, and it's inexpensive. The test uses the principle that the metabolism of either lactulose or glucose as its carbohydrate substrate by bacteria will produce either hydrogen or methane. Now, we talked about typically, I think it's probably something in the order of about 70-30 or 80-20. Most people are hydrogen-forming SIBO sufferers, with maybe 20% or thereabouts who are the methanogens, the methane-producing sufferers. Now, both hydrogen or methane can be detected on breath tests, and this is totally the standard de facto test for SIBO, is a regimented analyzing of the breath, and we'll cover that in a little while. So, talking about the numbers, in terms of a rise of more than 20 parts per million from the baseline of a person's breath in hydrogen within 90 minutes, or a methane level of more than 10 parts per million, are termed positive results. Now, in patients without specific risk factors for SIBO, both upper and lower endoscopies are generally performed to rule out other causes like atrophic gastritis or Crohn's disease as one of those inflammatory processes. Now, if endoscopies are normal, imaging studies are done to rule out partial obstruction, diverticular, fistulas, or other inflammatory findings. All these procedures need to be weighed according to the risk-benefit. The two processes that most commonly predispose to bacterial overgrowth are diminished gastric acid secretion and small intestinal dysmotility. Now, disturbances in gut immune function and anatomical abnormalities of the GI tract also increase the likelihood of developing SIBO. And diminished acid production, the hypochlorhydria, is a risk factor for SIBO and can develop after colonization with Helicobacter pylori or as a consequence of aging. Now, we've mentioned H. pylori in the past as a well-characterized now bacteria that can take up residence in the stomach and certainly can be a type of dysbiosis that people can suffer with. So Helicobacter can be fairly successfully eradicated with antibiotics, but certainly there are some people that are totally positive for H. pylori, and this is also another causative organism for stomach ulcers, and certainly I think when people have recurrent ulcers, should definitely look into whether they're infected with H. pylori and to treat that principally rather than solely protecting the ulcer, and or using antacids, you see, which is another bad way to go. Antacids and proton pump inhibitors are really not what you want to be using. So we mentioned already that both those two things, the proton pump inhibitors and these kind of antacids, can also predispose a person to SIBO. Now, we'll cover some of the risk factors for the development of SIBO. I just want to say again, you're listening to Ask Your Herb Doctor, KMED Garberville 91.1 FM. From 7:30 to the end of the show, 8 o'clock, you're invited to call in with questions related to SIBO or gastro-intestinal disturbance or disease, or any other questions related to alternative medicine. The number is 707-923-3911. Now, it's particularly important to consider the coexistence of SIBO in patients with chronic pancreatitis, cystic fibrosis, celiac disease seemingly resistant to treatment with a gluten-free diet, inflammatory bowel disease flare-ups, particularly in patients with Crohn's disease, exacerbated symptoms following ileocecal valve resection, and symptoms of decompensated liver disease with ascites at risk of spontaneous bacterial peritonitis or IBS. So these are kind of confounding factors that exacerbate this situation. So complications associated with SIBO include the structural anatomical defects that can happen with patients' intestines. So small intestine diverticular, which are outpouchings of the intestinal epithelia. These are commonly sites of inflammation, and these can in their own right predispose eventually, if untreated, to polyposis and cancers. Small intestine strictures. Now, this can be caused by radiation, for sure, and some medications can cause strictures of the small intestine. And then, of course, the inflammatory bowel diseases, both ulcerative colitis and Crohn's, both normally result untreated over long term, can result in strictures. Now, obviously, the stricture, the tightening or the narrowing of the lumen of the intestine is caused by all the repeated inflammation, and that inflammation upon inflammation, unresolved and unmitigated there, can totally resolve in fibrosis, and that lack of elasticity again for that tube results in a tight spot or a stricture that doesn't really yield to the typical peristalsis that would happen when somebody's eating their food. So those two, intestinal diverticular, the pouches, and strictures, both from inflammatory bowel disease and or radiation in the extreme, can be causative. Now, surgically created blind loops and resection of the ileocecal valve. Both those two surgical procedures commonly result in SIBO, and we'll go through that in a little bit. Now, fistulas between the proximal and distal bowel This can happen through inflammatory bowel disease for sure. Gastric resection can be another complication here of SIBO. And then the motility disorders, so the disorders of the movement, the typical rhythmic pattern that the intestine has for moving food along the intestine. Things like gastroparesis, which is a delayed gastric emptying. So, after about 90 minutes or so, when you've eaten food, within 90 minutes, the chyme that's produced by the chewed up food and the action of all the enzymes and all the digestive juices in the stomach should result in emptying into the small intestine for absorption. But some people have a very delayed emptying, and the food it really doesn't move very quickly. Now, small bowel dysmotility is the next thing. So when the small bowel itself doesn't have a lot of rhythmic peristalsis, this can be another cause of SIBO, because there's not adequate movement from the stomach through to the rectum the way it should be. When it's really slowed down, you can get some retrograde movement of bacteria. So this is another typical reason or complication associated with SIBO.
That's called reverse peristalsis.
Yeah.
And that can happen more frequently than was once thought. And you can sometimes smell it on people's breath. People that have very, very bad breath, it can be because they're actually having, instead of the peristalsis going from your mouth down through your intestines, it's coming from your intestines back up to your mouth.
Okay, then celiac disease. Again, this is a kind of gluten enteropathy. So for people that really are allergic to gluten, where their body actually attacks the villi or the gluten, the gluten itself is a damaging agent to the villi and will cause the kind of blunting and the removal of the villi essentially through uncontrolled exposure to gluten. This certainly is one of those things that can affect SIBO. Then also irritable bowel syndrome that we've mentioned. And then there are metabolic disorders that predispose patients to SIBO. Diabetes is one of these through uncontrolled sugar elevation. And then hypochlorhydria. So we mentioned the things like the proton pump inhibitors and the antacids that decrease your stomach acid. Both of these will predispose the patient to SIBO, because that gastric pH is extremely important for maintaining the right bacterial populations and preventing overgrowth of bacteria.
And that's why taking omeprazole and all those acid blockers are so dangerous, because you're allowing food to enter into your small intestine from your stomach without the adequate acid to maintain the proper, not the proper bacterial balance, but you don't want any bacteria there in your small intestine. And if food's coming out of your stomach with not enough stomach acid, it's going to be feeding bacteria.
There are other organ system dysfunctions that have been well characterized as predisposing people to SIBO, and those are things like cirrhosis. That's certainly been associated with SIBO. Renal failure, and then pancreatitis. So those three main organ dysfunctions can predispose people to SIBO. And then the immunodeficiency states, Crohn's and celiac disease certainly have higher numbers of those patients presenting with SIBO. We mentioned the PPIs, the proton pump inhibitors, and anything that causes gastric acid suppression over the chronic long term. So there's a significant amount of interest in SIBO in the generation of IBS. So many IBS symptoms are non-specific. Things like bloating, distension, cramping, abdominal discomfort, and can mimic the symptoms of SIBO. Long-standing and poorly controlled diabetes can injure the enteric nervous system, leading to disordered GI motility. So as we mentioned, the things high sugar, constant chronic high blood sugar can certainly disturb and interfere with accurate nervous conduction. So the enteric, the bowel's own nervous system can be poorly regulated by increasing amounts of gastric glucose in the blood. Now, we mentioned gastroparesis, where there's really a deranged movement of food from the stomach through to the intestines. It's just slowing down. It's not getting the right nervous stimulation from the vagal nerve and its feedback. And then neuropathic small bowel motility disorders, that both of these are associated. Now, a recent study found that SIBO was present in 43% of diabetic patients with chronic diarrhea, and 75% had a significant improvement in their symptoms after being treated with antibiotics. I know Dr. Pete was pretty, he was actually quite supportive of antibiotics, and his main rationale for that was that antibiotics themselves were beneficial for gut bacteria, and that a lot of these things that people suffered with really had a seat in their seat of health was in their bowel. And so, he was quite big on antibiotics. He never shunned them. And most people, when they're looking at alternative medicine, are kind of brainwashed, if you like, by not using antibiotics and considering them as a poor choice of treatment, but actually very useful for a lot of people.
Well, I think when people would talk to Dr. Pete and say, look, I took antibiotics and I was able to eat this food and that food and I felt so much better, then he looked at it as a way that someone could relieve themselves of that bacterial endotoxin if they were unable to try to do it through eating a diet that blocked them. That's why he recommended carrot salad so frequently, because it suppresses bacterial overgrowth in the intestine because it's not digested. That carrot fiber is actually not digested. So raw carrots will carry on having a antibacterial effect all the way through the intestine, and it helps increase motility, which helps keep things moving along and not growing bacteria as much. But I've heard, like we've all heard him say several times, how did that make you feel when you used antibiotics, or when someone uses antibiotics? And when they said, oh, I felt great, then he would think that, okay, well, those are the type of people that need to be super careful with their diet, because obviously they have some bacteria that are making them ill. Of course, ideally, he would always want people to try to figure out the diet that helped them not feed those bacteria rather than taking antibiotics. But that can be very difficult for some people to figure out what foods they should and shouldn't eat. So in the interim, sometimes he would recommend a short course.
A recent study evaluated the role of SIBO in 87 consecutive patients with chronic diarrhea. All patients underwent extensive testing to exclude structural, metabolic, inflammatory, and acute infectious processes. In addition, celiac disease and inflammatory bowel disease were ruled out by both lab and endoscopic testing. And the authors reported that SIBO was present in 33% of the patients using small bowel culture compared to 0% in healthy controls. Now, hereditary fructose intolerance is an inborn error of fructose metabolism caused by a deficiency of the enzyme aldolase B. Individuals affected with hereditary fructose intolerance are asymptomatic until they ingest fructose, sucrose, or sorbitol. Now, lactose intolerance is also caused by a lessened ability or a complete inability to digest lactose. It's often not the case that people are truly lactose intolerant. There are some people, but the majority of people can very slowly get accustomed to producing lactase again by ingesting very small amounts of milk. Okay, so humans vary in the amount of lactose they can tolerate before symptoms develop. And symptoms may include abdominal pain, bloating, diarrhea, flatulence, and nausea. And these are the things that most people complain about. If you ask them, milk is one of those things that would be very easy to absorb and is a complete food. Would you drink more milk as a way of getting, a good amount of calories in a most easily absorbable form? And Dr. Pete was a big supporter of milk as a good food for the intestines, for sure. Now, complications of SIBO range from mild. Sort of people can have fairly mild symptoms with it, including things like diarrhea and minimal vitamin deficiencies. Then it can become severe in some people, including malabsorption and neuropathy due to fat-soluble vitamin deficiency. So the nutritional consequences of SIBO result from maldigestion and malabsorption of nutrients in the intestinal lumen. And the latter, the malabsorption of nutrients, secondary to microscopic damage to the small intestinal mucosa, which diminishes the absorptive capacity of the microvilli. So fat malabsorption occurs as a result of bacterial deconjugation of bile salts. In addition, free bile acids are toxic to the intestinal mucosa, resulting in mucosal inflammation and malabsorption. Now, these deconjugated bile salts are reabsorbed in the jejunum rather than the ileum, leading to impaired micelle formulation, as well as fat malabsorption and deficiencies, again in the fat-soluble vitamins we mentioned, A, D, E, and K. Unfortunately, symptoms rarely develop. However, in severe cases, night blindness from vitamin A deficiency, osteomalacia, and tetany due to hypocalcemia, that is low calcium, prolonged prothrombin times from vitamin K deficiency, or neuropathy, retinopathy, and impairments in T-cell function can occur. So these are all the things that you could expect to see in a patient with long-term chronic fat-soluble vitamin deficiency. So you're listening to Ask Your Herb, Dr. Kami D. Galville, 91.1 FM. It's 7:36 now. From now until the end of the show at 8 o'clock, you're invited to call in. The number's 707-923-3911. We're just going to wrap up SIBO here and then just cover some breaking news about mRNA vaccines and cardiac arrests. Okay, let's just finish up this bit here, and then we'll cover some of those herbs that we definitely are indicated for the treatment of SIBO, as well as go through the breath testing part of it. So now, at present, the lactulose or glucose hydrogen breath test is the most commonly used diagnostic tool. The collection of the samples relies on collecting alveolar air samples. Patients are generally instructed to avoid ingesting unfermentable carbohydrates like whole grains, bread, pasta, etc. After an overnight fast, a baseline hydrogen sample is collected, and then 10 grams of lactulose or 50 to 80 grams of glucose, depending on which one they're going to take, is administered in 120 ml of water. And then end expiratory breath samples are collected every 15 to 30 minutes for a total of 3 to 4 hours. Generally, an increase from the baseline fasting hydrogen concentration to a value greater than 10 to 12 parts per million after a 50 gram glucose load, or greater than 20 parts per million following lactulose during the first 90 minutes of the breath test has been accepted as proof of SIBO. Now, Sarah.
So basically, when you swallow this lactulose, this is a fermentable carbohydrate that bacteria in your small intestine will start eating on, if I can use those words. They'll start fermenting it. And the gases that the bacteria produce as they eat the lactulose that you've swallowed can be detected on your breath. And that's how they diagnose the SIBO, how they diagnose the presence of the small intestine in your, these bacteria in your small intestine is by analyzing your breath sample. Like Andrew said, 20 minutes, 15 to 30 minutes intervals for 3 to 4 hours. And if you have any activity of bacteria digesting that lactulose, it's going to be picked up on your breath. That's going to be analyzed by a laboratory. And that says, yeah, you have bacteria in that small intestine where they shouldn't be. You shouldn't have any of these gases getting picked up that are produced by bacteria. And that's why some people can have odd smells on their breath after they eat certain foods. It's, I don't know, maybe they should train animals. I know they've trained animals to look at, to smell cancer on people's breath, but I'm sure that would be really interesting to train humans and animals to be able to just smell somebody's breath after they've eaten something, to be able to determine and diagnose whether they have some abnormal bacteria activity.
Okay, so nutritional support, particularly in those patients with weight loss or vitamin and mineral deficiencies, is an important component of the treatment of SIBO. And supplementation and maintenance of vitamin B12, as we mentioned, which are typically lowered, and fat-soluble vitamins A, D, E, and K with correction of calcium and magnesium deficiencies are key components of treatment. Lactase and fructase deficiency may develop due to inflammation of the small bowel brush border, and dietary restrictions are often advocated, although this has not been prospectively studied. So SIBO may cause various clinical manifestations as well as have an asymptomatic course. Some people don't even have symptoms, but they could still be qualified as SIBO patients based on breath analysis. The most common symptoms reported by 2/3 of patients with SIBO are abdominal distension, excessive gas accumulation and flatulence, the feeling of abdominal fullness, diffuse abdominal cramps, and altered bowel habits, predominantly diarrhea or alternating bowel habits, sometimes constipation. And the patient may also complain of chronic fatigue and impaired concentration.
And also belching. Did you mention belching? That's a symptom of SIBO.
I don't think I did. Okay, so constipation accompanies SIBO when bacterial overgrowth is primarily due to methane producing, so the methanogenic microorganisms, such as Methanobrevibacter smithii, as one of those causative organisms that can be plated up and detected. And notably, methane is produced, as I mentioned, by archaea, the domain of microorganisms distinct from bacteria. Consequently, the word bacterial in the original name of this condition, methane SIBO, posed a terminological conflict which has been resolved by the introduction of a new term, intestinal methanogen overgrowth, or IMO, to express a diagnosis in patients with a positive methane breath test. Okay, so moving on to herbs that are used in the treatment of SIBO, certainly in the early stages of it, to reduce bacterial numbers to a point where the bactericidal type herbs that will totally outcompete those forms of bacteria. So things like cascara, again, Dr. Pete mentioned cascara for many different things, definitely for constipation is one of those things that people shouldn't have over and above having an easy bowel movement daily. But Cascara sagrada, he always mentioned that had a antibiotic effect and a structural similarity to tetracycline in the anthraquinone moiety that was responsible for its activity, which is to bring a little water into the bowel over and above what would be chronically dehydrated from it in constipation, but also that the antibiotic effect would have a regulating effect on bacteria locally to reduce populations of bacteria that would be causative. So constipation, mainly from methanogen dominant forms of SIBO, generalized dysmotility as causative factor in the development of SIBO. So dysmotility, so when the bowel is just not moving or there's any form of gastroparesis and the intestine is moving slowly, that's also going to predispose you to constipation because of that water content. It's just going to become more and more removed, and as it gets drier and drier, you're certainly not going to evacuate the same way as you would if it was moist. Okay, I think we have a caller on the air, so let's take this first caller. Caller, you're on the air. Where from, and what's your question?
Hi, I'm from the San Francisco Bay Area, and I'm wondering if, when it comes to treating SIBO, do you think that potentially just avoiding foods that feed your gut bacteria could be helpful, or could that lead to malnourishment?
Yeah, I think in the short term, that's a great idea to try to figure it out. But ideally, people want to find out what it is that's causing the inability of them to eat those foods. And if it is bacteria in the small intestine, to try to deal with that. And one of the orthodox ways to treat SIBO is with some very specific antibiotics for a specific amount of time, along with very specific diets of avoiding those fermentable bacteria towards the end of the antibiotic course, eating a lot of the foods that feed the bacteria at the beginning of the antibiotic course, and towards the end, removing the food so that you keep the bacteria nice and happy when you start taking the antibiotics, so they grow and they're not starving and trying to put up their walls of defense. But basically, the specific protocols and how to treat that. And yes, it can, over the long term, if you do avoid a lot of different foods that are nutritiously important and essential, over the long term, you could have some serious problems with nutritional deficiencies.
Do you Do you add beneficial bacteria to try to repopulate?
you do.
How do you do that?
Later
Well,
on.
some people with a SIBO have experienced worsening of their symptoms when they take probiotics because I don't think we really know why, but we do know that some people have worsening of their symptoms. SIBO people have worsening symptoms with probiotics, and other people have improvement in their symptoms because I think the improvement part, not sure why people get worse with it, but I think the improvement part is those bacteria are dominating the SIBO bacteria and they're taking up residence. But really, you're not supposed to have even the probiotics in your intestines, right? When you eat yogurt or cheese with probiotics, it goes into your stomach. Your stomach has a lot of hydrochloric acid, and that digests and kills, essentially. It should kill most, if not all, of the bacteria. So maybe you're
And
getting...
they're only thriving in the lower intestine?
And they're only supposed to thrive in the lower intestine.
And
So
just if enough make it through the upper intestine to populate?
yeah, but they're not. Yeah, and you.
enough.
Well, I know that's the theory, and maybe fecal implants. That's why the FDA has been doing research on fecal implants because they are saying that the bacteria in the lower intestine are really important. But maybe the people that react to the SIBO patients that react to probiotics are because their small intestine doesn't want these other bacteria. I don't know. We don't know the reason why, but basically it's something that you'd have to trial and error and see. But again, too, you don't want to have to live on probiotics the rest of your life, right? You'd want to try to figure out what diet you need to eat, and if it's nutritionally balanced, then great, stick on that diet. If it's not, then you need to try to find a way to eradicate the bacteria that are causing you the problem. I mean, that's the end goal, is to try to get rid of those bacteria out of your small intestine. And there are lots of herbs, like Andrew was talking about, cascara, and there's lots of bitter herbs. Bitter foods are really great because that increases your stomach acid concentration so that when the food goes down into your small intestine, it's already been treated with hydrochloric acid, so there's less to feed the bacteria, if you want to look at it like that, because hydrochloric acid is, very, very, very powerful. Bitter herbs
Can
like...
I ask another question?
Yes.
I'm also curious because I have noticed that, so I have tried the carrot salad for several years, and then I started noticing getting bloating from it and other bad symptoms. And then when I removed it and then switched over to more of a mushroom as a fiber, then I felt better. So I'm curious, if you have SIBO, do you think that your gut bacteria could start learning how to feed off of foods that are supposed to be antimicrobial?
Yeah, I think, they just have become resistant to it, like you get bacteria that are resistant to antibiotics. And the bacteria that are in your small intestine, they might not be, carrot fiber might not be antibacterial to them. They might be resistant to the antibacterial nature of carrot, and they might enjoy it and feed off of it. So, I mean, the same could go with the bamboo shoots or the other non-fermentable fibers. Dr. Pete would recommend the bamboo shoots, the carrots, and or the mushrooms, well-cooked mushrooms. You have to see. That's why you'd always say, well, how does that make you feel? What is it doing in your intestine? Is it feeding these bad bacteria, or is it killing them and giving you a little bit of relief from the bacterial endotoxin that they produce upon feeding of these fibers? And like Andrew said, they've discovered most of a stool is bacterial byproducts. And Dr. Pete told me this story one time about the Tibetan monks who aimed to produce a golf ball size stool once a week. They didn't want anything more because they said anything more is a waste. And their main diet was yak milk. So when you drink milk, generally you produce very little stool because there's very little fiber to feed bacteria that produce this large stool. So people think it's great, I'm having these huge bowel movements and it's just wonderful, but really that's a lot of fermentable fiber that your body's having to process and get rid of through the use of a lot of bacterial breakdown. And whilst we don't want to be producing maybe one stool a week because we don't drink just milk, there's a balance there between how much fiber are you actually putting in your intestines and how much do you really need And how much is, well, what's it make you feel like? You have to go back to that. Does that bowel movement with a lot of stool feel good, or does it feel like it's just a little bit too irritated? Just listen to your body.
Okay, great. Thank you so much.
Thank you for your call.
Okay, so there is a very specific way of treating diagnosed SIBO in terms of the protocol and the steps towards doing this to make it successful. It is notoriously difficult, unfortunately. There are patients that rebound, but in terms of identifying the food groups that trigger hydrogen or methane production, to be aware of those is certainly part of the education of the patient towards not eating these foods. But typically, for example, people that have a constipation dominant form of methane producing bacteria, then obviously Cascara sagrada and licorice are two of the main herbs of choice to promote a looser stool. But essentially, the whole concept of the low FODMAP diet is something that should certainly be discussed. I think it'll take too long at this point in time because I want to try to get to the mRNA damage to the cardiac muscle and how this has been now shown to be a cause of the sudden death, especially in athletes. I wanted to make sure we can try and get hold of that data here and cover that before the top of the hour. But ultimately, the low FODMAP diet, and FODMAPs are the fructo oligosaccharides, disaccharides, monosaccharides, and polyols. So these are components in food. So any of these starchy products that Dr. Pete was always very opposed to starches and how starches would be very detrimental to a person's health and to minimize any kind of starch. So ultimately, as Sarah mentioned, things like bamboo shoots and carrots fiber was one of those things that, whilst it may have been classified that way, was certainly not utilized by any of the bacteria and was relatively unchanged as it passed through the GI tract. So low FODMAP diets, one of those very first things to do in any patient with SIBO, to try and restrict the food for these bacteria so you reduce the numbers as much as possible before actually treating. Once that's happened, after about 4 weeks of being on a low FODMAP diet, patients should see a decrease in their belching, a decrease in their abdominal distension, etc., on all the GI symptoms. But then at that point, you'd introduce antimicrobial herbs. So typically those herbs, things like Berberis vulgaris containing berberine. Berberine has been shown as a well-characterized antimicrobial. And then oregano, the oil of the oregano, certainly, again, another characterized antimicrobial. And then, as Sarah mentioned, gentian or other bitter herbs that stimulate hydrochloric acid production in the stomach. Then there are other herbs for sure, things like curcumin from turmeric, and then boswellia, the frankincense, has been well characterized again in the treatment of a lot of gastrointestinal disorders. And then ginger, again, another excellent herb for the GI tract. And we mentioned peppermint as an enteric capsule, so that it gets past the stomach and actually gets into the small intestine, where it can have a beneficial effect. Then there are the things, the two plantagos, both ovata and psyllium. So both of these, the light, sometimes called pale psyllium, and the dark psyllium, both of these can have a very positive beneficial effect on both constipation and diarrhea. They're bulk-forming mucilaginous products, and these can, again, like I said, have a bearing on the water fluid content or not of both diarrheal and constipation types. So there's a very specific approach to SIBO in terms of first reducing the numbers, then using bactericidal herbs, and then the probiotic. So the probiotic is one of the last things. So basically you can improve the motility of the stomach in conjunction with these herbs, and then when everything has died back and the patient's no longer got SIBO on a breath test, then a good probiotic can be used to improve bacterial colonies that should be there. Okay, so
And of course, also make sure your thyroid function is working, because if you're low thyroid, you'll have a decreased amount of salivary enzymes. So in your saliva, you won't be breaking down food properly and be providing food for bacteria in the small intestine where they shouldn't be. And also you'll produce less stomach acid. So it's really important to make sure your thyroid is working right and your temperature is reaching 98.6 after meals and your pulse is 80 plus beats per minute. That's a good general recommendation for adequate thyroid function.
Okay, so just remind me again when we need to be wrapping this up, because it's 5:02. Do you think we should be wrapping this up now?
No, do your last thing and then wrap it up.
Good, okay.
You'll hear the music when you need to wrap it up.
Okay, there you go. Right. Make sure we don't upset
But you do it
anybody.
right away when you hear the music.
Okay. All right. Well, we won't take any more calls here at this point in time. So I want to get onto the December 29th paper that came out here in England from a Dr. Philip Macmillan, who's a UK cardiologist, a well-respected cardiologist. He knows what he's talking about because he's a cardiologist, right? Okay. So the whole point of COVID and vaccination and the sudden deaths that were caused undoubtedly now and categorically proven to be due to the vaccine and its effects on the myocardial heart muscle. Well, this cardiologist has been looking at a pioneering paper that's done by some Japanese scientists called the Assessment of Myocardial 18F-FDGG, which is a fluorinated radio-labeled fluorine, glucose, rather, labeled with 18 fluorine as a radioactive product, so it can be detected on PET scans and CT scans, typically used for cancer patients for detecting cancers. So when you consume 18 fluoro FDG, it typically is taken up by rapidly dividing cells, and cancers, being those rapidly dividing cells, tend to show up as darkened areas on a PET scan. So the papers came out with a scare, if you like, at the beginning of this year, the JN1 variant, all right, as if we're not tired of it all. The JN1 variant could cause a global heart failure pandemic. So anyway, this paper that was done by the Japanese highlighted these findings. The study included 1,000 subjects. 303 were unvaccinated, 700 were vaccinated. What they did, they had these vaccinated participants, and they found that the myocardial 18F-FDG uptake was greater in the vaccinated versus the unvaccinated patients. And when they looked at it, they saw the vaccinated group also showed higher uptake in liver and spleen compared to the unvaccinated group. But the most significant part of it was that the cardiac muscle was specifically darkened, showing this radio-labeled fluorine. Now, organs that utilize a lot of glucose will selectively take up high concentrations of radio-labeled 18F-FDG, and on a PET scan will show up as a darkened area compared to the lighter background color of tissues which have not taken up or utilize the radio-labeled glucose. And PET scans with this radio-labeled marker is routinely used as a diagnostic imaging modality for cancer screening and follow-up evaluation of cancer treatment. As the cancer regresses during treatment, decreasing uptake and decreasing contrast is visualized. Now, cancer cells tend to use high concentrations of glucose as they don't tend to use the mitochondria. Now, when compared with non-vaccinated patients, asymptomatic patients who received their second vaccination 1 to 180 days prior to imaging showed increased myocardial 18F-FDG uptake on PET scans. Now, looking at cardiac physiology, what's wrong with taking up glucose? Well, heart muscle primarily utilizes free fatty acids for energy, 60 to 90% of it, with 1 gram of free fatty acids liberating 37 kilojoules of energy broken down in the mitochondria. The brain and heart primarily use free fatty acids for energy compared to glucose as a 10 to 40% case, yielding only 16 kilojoules per gram, so less than half of the energy. Now, when putting your heart under stress, meaning energy is needed to power the activity of cardiac muscle contraction, free fatty acid energy metabolism via the mitochondrial pathway yields a much higher energy output than glucose. As is seen in the radiological imaging done on the 2 cohorts tested, namely vaccinated versus unvaccinated, the cardiac muscle of the vaccinated takes up this 18F labeled glucose primarily, and none is used by the unvaccinated heart, which is still using free fatty acids for production of energy. Okay.